All right, I think that we can go ahead and get started. Thank you so much, everyone, for joining. Good morning, good afternoon, good evening. We're really excited to be launching our Christian Health Asset Mapping Consortium today. We've been planning for this for the last year or so, and we're really excited to get it off the ground today. Thank you for your participation joining in today. A special thank you to our 6 founding partners who have brought so much insight and collaboration over the past year. If you're new to Christian Connections for International Health, we're hosting this webinar today. We're an international network of approximately 115 Christian organizations and 15 affiliated partners, as well as a few hundred individual members, all working in over 90 countries. CCIH's mission is to promote health and wholeness from a Christian perspective and provide opportunities for capacity building, networking, fellowship, and advocacy. And CCIH is happy to serve as the Secretariat for this Christian Health Asset Mapping Consortium. I would love to start with a brief prayer, if we could all bow our heads. Lord, we are so thankful for the opportunity to gather together today. We welcome you in this space, and we thank you for the guidance you've given us so far. We're grateful for the work of many Christian organizations, community programs, hospitals, facilities, research institutions, training facilities that serve communities around the globe in your name, Lord. Thank you for bringing us together for our shared work, our shared vision, and we pray that we keep our eyes set on you. We pray for all those who are sick right now, battling COVID and other illnesses, and places in the world where there's a lot of conflict right now. In Jesus' name we pray, amen. Thank you all for joining. We can take a look at the agenda for today. So we will be spending some time talking about the background of the consortium, what our initial actions will be. We'll hear some statements from founding members. We have guest speakers from Usaid here today to share some remarks, and then we're happy to take your questions and have some discussion. Throughout the launch, please feel free to put your questions in the chat box. There's not a separate Q&A, so we'll be keeping track there. As well as during the discussion section, feel free to come off mute. We see this as kind of an informal thing, so don't feel shy about that, and we're happy that you're all here. So I am going to turn it over to Doug, who will share a little bit about the background of the consortium, challenges, and our opportunity to meet those challenges.
Thanks so much, Carolyn. I really appreciate it. And also good afternoon. Good morning, good afternoon, good evening to everybody. Can you hear me? Just want to make sure. Okay, great. I am thrilled to be able to be here and speak to you today because this work has been in development for a while. Let me set a little bit of the context of where this came from. I think many of you know, as we've grappled to describe the scope and scale of all of our Christian health assets around the world, there's been very few standard or consistent resources. Yet we know that Christian organizations provide a substantial share of health services in facilities, in congregations, in communities, and they truly reflect the health ministry of the global church. Many of us have used the Lancet 2015 articles that came out that described how many faith-based health facilities there are as a percent of total. They might use terms like percent of total hospitals or total healthcare. And the challenge for that is now that data is 15 or even 20 years old that was underlying what was in that. And so we all know these statistics that 20 to 50% of services are faith-based. And it asks more questions, frankly, than it answers. Where are those services? What type of services? Are they urban? Are they rural? Or both? How many service locations are there? What do they offer? How are they organized? How do we engage with them? I think partners are trying to figure out how to work with this vast array. And we know from some of the data efforts that are going on right now that there are tens of thousands of facilities and at least as many community-based or congregation-based health programs around the world, which is remarkable. Just think about that for a minute, tens of thousands. USAID also raised some interest in this, and I want to give a special shout out to one of our founding members, Bruce Compton, who worked with USAID back in 2019 for a meeting that happened in January 2020. Remember when we used to go to meetings in person? And Bruce worked with the Global Health Bureau to bring together, I guess there were maybe 15 or 20 people that came together to talk about this challenge. And the challenge was, that isn't there some existing reservoir of information that we could tap into? And many of us left that meeting challenged, thinking, no, there's really nothing consistent, but we have to do something. Then immediately after that, of course, is when COVID broke, and several of us on this call today were on the receiving end of phone calls. I remember one in particular that several of us got, where the question came from somebody at USAID, literally these words: I need a list of faith-based hospitals in 15 countries by Monday. And we were immediately challenged, realizing nobody had a single place, authoritative place to turn to try to get some answer on that. So, but we also know that several organizations have been working on this and trying to work on parts of the solution. I think it's really important to reflect on why we are doing this. Frankly, our donors and partners are trying to figure out what is the unique role of faith-based organizations. What is their breadth, depth, and sustainability within community settings? They want to integrate faith voices in national strategies, and they want opportunities to identify best practices and innovations by working with this important sector. And so if we don't have information about that, the scale and scope of these services is going to limit that. So maybe to the next slide. So move to the next slide, please. Oh, there we are, thanks. Nope, sorry, back one. So our challenge is really to try to address this undercounting of Christian health assets and the problem that it creates of exclusion from planning, partnerships, and research. We need data on health assets that is no longer inconsistent and fragmented, that don't have standards, where there are few or no central repositories, especially for information about community programs. So we want to address the fact that has led to this underrepresentation in government and donor-led health initiatives, as well as health data initiatives. All of that, of course, affects funding, visibility, and capacity building opportunities. And frankly, also, the global church doesn't really know and can't speak with a single voice about what is the scope and scale of Christian health assets. So we want to help the church as well to address that. Now we can go to the next slide. So it's important then to think about, what is this Christian health landscape? What is this thing that we are trying to describe and get data around? And this is how several of us have started to envision this. The Christian health landscape includes Christian health facilities, and that's what many of us have tended to focus on because it's easy to count. How many dispensaries or hospitals are there in the world? Then there are community-based programs, community health programs, and then related congregational or church or parish-run health programs. All of those make up major components of the Christian health landscape, health asset landscape. But in support of those are everything from Christian health networks, like the Christian health associations, drug and medical supply organizations that provide support for those that are providing services, health worker training programs that are training our nurses, our clinical officers, our physicians, and there's even Christian specific programs that are doing that training. And then, of course, the many international support partners that exist, from NGOs to mission agencies. Who are all of these, and how are they working together? That's the big question. That's the landscape. So we need a comprehensive data and mapping strategy to accurately reflect the breadth and complexity of Christian health assets. So that's what we're trying to shape here. So with that in mind, we started we'll explain a little bit more about the who the we are in a moment. But several of us got together to start thinking about what a consortium would look like. What would the elements be for that? So move on to the next slide. And so this is what we started to put together. The vision for this is stakeholders to Christian health assets will have better information about Christian health asset data and the nature of those services, especially in low and middle income countries. And the mission then of this consortium will be to increase resources, learning, and partnerships in Christian health services by improving understanding of the nature, scope, and location of those services. And the values then, and this is important, the values of this are transparency, data awareness, data quality, partnership, and inclusive data governance. If you can just hit the next slide. I want to highlight that one point about the importance about inclusive data governance. One of the reasons for having a consortium rather than one actor simply say, we will amass all of the data, send all of the data, and we'll put it in a big warehouse and start producing reports. One of the concerns is that there are many health services, many facilities that do not work in conducive environments where maybe the governments do not encourage or support the Christian health services. They might even organize against them. And we've heard many stories around that and are aware of that. And also there's a concern about the confidentiality of data. When we start having contact information, for example, about who's actually the point of contact for a health facility, and you start having data that's flowing where there are individuals named with their email addresses and phone numbers, of course, that's a real risk. So we want to be very careful about data governance, and that's why we've identified that as a value. So the goals then for this consortium are to highlight information on Christian health services and programs, identify and maintain information about this health asset data, share information about health asset data and their benefits, improve representation of Christian health assets in national and global data, raise support or technical assistance to Christian organizations to improve their data, create a learning community around that, and then foster partnerships that analyze data and apply it for program development. So really, if you see what we're trying to start here is bringing together multiple organizations that have an interest in data. They may have data that they're working with, and we'll hear about that from some of our founding members. But some of the organizations that are getting involved also just want to help improve the quality of the data that's been part of that, or that is available. So that's what we're going to try to do in this consortium. So that's a little bit of the background of this, and I'm going to turn it back to Carolyn now. Carolyn will be leading the effort for CCIH's Secretariat, and so you should really get to know her and her thoughts around this, and we're grateful, Carolyn, that you're going to take it from here. So you want to outline the initial objectives, please?
Yeah, thanks, Doug. That's a helpful background to have. If we can go to the next slide. Perfect. So before I dive into initial objectives, I think it's good to note that this is still information. We're assembling the pieces, and this launching is an effort that will be in development for a while. So we're excited to get it off the ground, but we have a lot of work ahead of us to really develop and build this out. One of our first objectives will be to create a metadata or database of databases platform, which we can use to learn about data sets. So this would be descriptive elements like the type of data that's included, ownership, how often it's updated, who has access, future plans, what geography it is at, or it covers, those types of things. So it's really a summary of the data. The note at the bottom of the slide is really important. At this time, we are not trying to create a warehouse of all Christian health assets. We're just trying to kind of come together and create summary descriptives of who has the data and where is the data at, so that people, donors, different partners can follow up and see, okay, I see in this country we have X, Y, and Z working here, and maybe these are the people I need to reach out to, or I'm planning this project, how about we collaborate with all of the orgs working in this country. And so that is our vision for one of our initial objectives. That includes the summary data that could be shared publicly that would be produced out of this registry. And so we see a platform or hub that has a dashboard. You can see what's there. You can look into maybe one country or one type of health asset. Say if you're really interested in community programs, looking at where those are at and who's working on community health programs. And so that's something that we're looking at for upcoming this year, one of our initial objectives. We're really wanting to put together a list of resources that would be helpful to partners on strengthening data on Christian health assets. So anywhere from helping with mapping efforts to helping with data governance, different resources pulled from different places that can be useful to people as they're pulling together information and making sure everything stays private. Can you switch to the next slide? So I wanted to just share a couple of graphics that from our initial registry data. So in order to test the registry, we had our 6 founding members fill that out for their organizations. And so you'll see the sample size is small, n equals 6 for this. And we have the geographic distribution as well as the type of Christian health assets here. And you'll see, even from a small sample size of just the 6 founding partners, you get a really good distribution of geographies and Christian health asset types. So you can see a spread out between health networks, hospitals, health centers, dispensaries, training institutions, research institutions, community-based organizations, mobile health assets, and others. There's a really good distribution there, and we just expect this to grow in the future, as well as the geographic distribution. There's not one part that's heavier than the others right now. I'm sure we'll see that change as we get more registry info, but it's good to see what type of information we'll see scaled up in the future through this registry. Next slide, please. So you've heard them mentioned a lot, our founding members. You'll see them listed at the top. There's 6 organizations that we have really been working closely with over the past year to get this on its feet. And so you'll see the Catholic Health Association, International Outreach, Christian Connections for International Health, the Dalton Foundation, the International Christian Medical and Dental Association, Africa Christian Health Associations Platform, and the World Council of Churches. At this time, if one of you or more than one of the founding partners want to come off mute and say a few words about your participation or how you see this benefiting your organization, that would be great. I will talk a little bit about our initial work while you can come off mute, and then I think Kathy can spotlight if you want your video shown. So this past year with the founding members, we had initial meetings to assess interest. We are also liaising with CCIH's data mapping working group, who is working in this area as well. Technical consultations from a mapping expert who's worked with years of data and with Christian networks, creating an MOU to frame our voluntary association, and 5 out of 6 of our founding partners have signed that MOU. And then we have the initial data registry set up. So I see, Bruce, you have your hand up. Feel free to unmute yourself and speak a few words. Thank you.
Yeah, I just want to say thank you to CCIH for really taking the leadership of this after the meeting that we had with USAID in 2020 before COVID. And as we brought that group together with USAID, one of the things that was said that day was it'd be great to have a graphic like what CHA has for their healthcare in the United States. And I can tell you that CHA does not do that by itself. We have to work with other associations, even in the United States. And it's still a real, given all the things we have, it's still a real difficult thing to keep our health assets up to date because it's a changing environment regularly. But just to give you an idea of what we do have, I wanted to we have a one page that a gentleman who did advocacy said, if we could just have this for Christian healthcare globally. And so just for US Catholic healthcare in the US, and we have both representative members and international members, but we have 668 hospitals, 139 of which are critical access. We have 249 trauma centers, 315 violence prevention programs, 378 hospitals providing palliative care, 315 with obstetrics, 1,589 continuing care facilities, 738,000 employees, and 1 in 7 patients is cared for in the United States. If we could get anywhere close to having just the numbers, it would be amazing as compared to between 20 and 50, or sometimes I see between 20 and 70% of healthcare in sub-Saharan Africa. It's so important, and USAID really did bring this on as well, because it was because of the new partnership initiative that I started getting asked so many questions. And then I called Doug and some others and said, are you getting these same calls? And after speaking to USAID, it really did make sense for us to come together and really think about this, because I figured if I was getting the calls, our friends at the African Christian Health Associations and others were also getting these same calls. So I'll shut up now, just to again say thank you to you, Carolyn, and Doug, and Scott, and all the other founding members that have really made this a possibility. And I look forward to continuing towards that, the efforts of understanding better what's happening in Christian healthcare globally.
Thanks so much, Bruce. Barbara, do you want to say a few words?
Yeah, sure. Thank you. I just want to echo what Bruce said just real quickly, and just thank CCIH for your leadership in this. I think everyone's gotten a sense of how difficult and challenging it is to come up with these numbers. Otherwise, we would have already done it. And I think we all probably agree how important it is. And thank you for highlighting that. And I just wanted to thank you, even to get to the place where we are today has taken a lot of work and time and effort. And so I thank you. And I thank, again, all the other founding members that were on here for this really important effort that I think will really bless and benefit so many when we can really articulate the extent and the benefits and the value of Christian healthcare. So that's all I had to say. Thank you, guys.
Thanks, Barbara, for those remarks. I think we should keep going, but if other founding partners want to speak up during the discussion section, please do. Can you forward the slide? Okay, great. Now we're really excited to hear a message from a representative of USAID Center for Faith-Based Neighborhood Partnerships. Amanda, would you like to go off mute and share a little bit from your perspective?
Yeah, thanks so much, Carolyn. Good morning, everyone. My name is Amanda Vigneaud. I'm the Deputy Director at the Center for Faith-Based and Neighborhood Partnerships at USAID. And I can't tell you how excited I am to be here. I really want to thank Doug and Carolyn and Bruce for inviting me to attend this launch event, and to all the organizations that are on the line for joining the effort. USAID and many of the groups on this call have a long history of partnership and cooperation, and so I'm really honored to be a part of the conversation today and help continue that tradition. And really, what a fantastic way to strategically demonstrate the contributions that communities of faith are bringing to development and global health work around the world. For those of you who don't know me, prior to joining USAID's Faith Office in 2019, I actually spent 5 years working in the agency's geospatial and mapping unit. And if you're not familiar with the Geo Center, it's an internal team of geographers and analysts who provide direct program support to USAID staff around the world. And during those 5 years of working directly with the agency geographer, I really came to appreciate the role that geographic analysis plays in development and the technical importance of many of the values that were discussed earlier today by Doug, from the data quality, the transparency, inclusive mapping. These things really help to illuminate not just the greatest areas of need in the communities where we work, but really the key assets that faith-based communities bring to the table to help us inform our development decisions and to prioritize the placement of our programming and our partnerships. And so at USAID, we really want to be a part of the conversation to help continue to champion that work and support our mission to really help build bridges with groups on the call and also with those in the communities that are very local to where we serve. In our office, we often say that partnership offers us the chance to model a new paradigm, and that's one of embracing pluralism. And, we believe that advancing pluralism in the development context can really help us heal the divides, not just in our nation, but also in our world. And so the unity that we see here today is really an important model for that. And so I wanted to thank you all for showing that in the consortium. And when I think about the types of partnerships that we're really aiming to cultivate at USAID and the geographic approach to development that we take, I just really wanted to come on and emphasize how excited we are at USAID about the launch of this mapping consortium, not just in the faith-based office, but also in the Global Health Bureau and in our Geo Center as well. I think most people in the room appreciate and know already the role that faith-based organizations play, whether it's local or international, in serving some of the most vulnerable populations in the world. And that, of course, has become so much more salient during the COVID-19 pandemic. And so this is really a timely launch. There's more coming out in just the next few weeks about things that our office is going to be spearheading. And so I'm really excited to help build the bridge and make connections between the work that's happening here in the consortium and the year of action that we're soon to launch at USAID on working with faith-based and community partners around the world to end the COVID-19 pandemic. So really just wanted to say thank you for the vision and for all of the organizations that are putting this together. I look forward to staying engaged in the discussion, and we'll be championing it in the years to come. Thanks so much. Over to you, Carolyn.
Thanks, Amanda. That was really great to hear. And so now I'd love to jump into our discussion section. We wanted to make sure we saved a lot of time for this because we want to hear from you, what you want to see in the consortium, any questions you might have, interests about, potential membership, or if you want to hear more. We'll be setting up a few different ways to communicate. One is we have a specific email for the consortium. So if you have questions, if you want to join a future listserv, you can always email mapping.consortium@ccih.org. But you're welcome to unmute yourself, share your video, and even make a few comments if you would like. And we're happy to hear from also our other founding partners who didn't speak or want to speak again from earlier. While people are thinking of their questions, we had a good question come in before the webinar started about, are you looking at, community health programs? We have a lot going in this area, not necessarily working with facilities or other. And I think probably at the beginning when Doug went through the Christian health asset landscape, that might have answered that question, but we get that a lot. Like, we have some data on facilities, but there's a lot of other types of services that we don't know a lot about. So we really want to focus on all types of Christian health assets so we can get a better idea of the scope and scale of the great work that our Christian health partners are doing. A great question from Yasmin. Have standard definitions of health assets been established? How many indicators are there? For example, inpatient hospitals include hospitals and with and without surgical wards. That's a great question. And we did a lot in the past year to make sure we're using terminology and standards that are understandable across the board. But I think that will be something that we prioritize for this coming year, is to make sure we have a good list or a document with definitions that we're using, so we make sure anyone who has interaction with the consortium, we are on the same page and we know what we're all talking about. So that's a really good point, and definitely something that we're going to look further into.
Carolyn, maybe I can say something about that too. Yeah, thank you, Yasmin. That's a great question, and it points to also when you ask the question about the standard definitions for all health assets. Actually, when you unpack all of them, as we went through that one graphic from health training institutions to drug supply organizations, we're now using language in describing health assets that maybe within specific countries or contexts is widely known or understood. But even within the broad or the breadth of all Christians working in international health, even defining health services that way is new. So we're in a way expanding people's perspective, I hope, of what is the Christian health landscape. As we get into data issues, I think that it's going to turn up a lot of those sorts of factors. How do we actually, and frankly, because each country is going to be slightly different, and some of the standard data sets and data frameworks that exist are going to be slightly different in how they treat that data. That makes it complex. It's one of the reasons why we're not tackling right now creating a data warehouse where people would pour in data, because that means we would have to grapple with that right up front. So at least to understand or to analyze things at a high level, like Bruce outlined for what they do with Catholic Health Association data, just getting that snapshot at a high level will be a good start for us.
Thanks, Doug. We have another great question from Dr. Chris Pranger. Nice to see you here. How practically will overlap with government services be addressed? Providing services is one issue, but number of persons served seems problematic in areas where pluralism in healthcare options is a big issue. This is definitely something that has come up in discussion over the past year, and we're continuing to look at. We see in this next year, hopefully we can put out some analysis and some articles specifically on this topic. Recently, we've been looking at the WHO data sets, and they have their set of what's tagged as a faith-based facility or a faith-based hospital. But when you search for like Christian type names like Saint Mary's or Faith, or I'm trying to think of the other terms that we searched. Maybe Scott, if you want to go off mute and explain more about this, you'll see that a lot of the facilities are tagged as public when it's clear they have some Christian connection or Christian collaborating or founding partner. And so there definitely is a lot of overlap, and there's a lot of faith-based facilities that aren't marked as faith-based facilities right now, even in public data sets. And that's something we're hopefully looking to help address and clarify in the coming years. I don't know if, Scott, you want to speak more to this issue, or?
I could say something about it if you'd like, Caroline. Caroline, I'm sorry, it's in the WHO data set, of course, we're looking at all of sub-Saharan Africa. So you have Francophone, Lusophone, and English-speaking faith-based systems that had established themselves there over the years. And some of these things have, of course, evolved and been acquired by governments and other things as well. So there's a lot of understandable confusion, yet, you know, in terms of whether they may be faith-based currently or not. Yet, as we look at the different parts of the data, we can see from things like the names that you mentioned, when a health facility is named St. Joseph's, St. Mary's, St. Sophia, there may be reasons for looking into further classification, particularly if it's listed as a public facility. But there's confusion about the private system as well, because many countries also have large, thriving private health systems. And so much of this is about trying to get clarity over these issues of ownership. But as Doug said, more from this broader high level perspective, because as you all know, when we start to get down into facility by facility, things start to get much more complicated. So as they said, we're trying to keep this at this higher level by looking at the content and summarizing the information that different partners submit as being within their data.
Thank you, Scott. And I guess we didn't formally mention, but Scott has worked with us over the past year as a consultant to CCIH in helping get this consortium running. So thanks, Scott.
You're welcome, Carolyn.
There is another question. Is the consortium interested in including privately owned Christian clinics in low-income communities, health facilities that are owned by Christians but not church mission, NGO-owned institutions? And that answer would be yes. We would like to look at all types of Christian health assets regardless of ownership. They don't necessarily have to be formally owned by NGO or a church. We would just really like to get an idea of the scope and scale of all Christian health assets, which I think the privately owned ones are we have less data and less measurement. So that would be a big area that we would want to continue summarizing and getting some descriptions on that. Thank you, Stephen. A question from Dan O'Neill. Would there be provision for anonymity for Christian health programs which are established in areas of the world where there are risks to identifying publicly as Christians? We received a couple of these questions before the launch, and so I think I'd like to turn it over to Doug to answer this question.
Yeah, thank you, Carolyn. It is a sensitive area for sure. We know that I think about to some of I think back to a very embarrassing question that I asked somebody once about hospitals in South Sudan before they were South Sudan. And I said something about what's your level of coordination with the government? And the response was, well, the government bombs our hospitals. And at that moment, I was actually working on some things related to geospatial data. And I just realized how dangerous it would be to disclose certain kinds of information, especially GPS coordinates of facilities in high risk or adverse environments. So that is kind of wired into what we're thinking. Another part of the thing, another part of the sensitivity that we've got is that who shares the data or who has the rights to share the data. Just because we might have access to a data set doesn't mean that we actually have the right or the obligation to share what's in that. And so how much right do we have? So we have to be very careful about that in terms of understanding what the needs are of people that have the data and own the data and what they want to have disclosed. So Dan, to your question directly, that's a really great approach. Is if we when we get to the point that we're analyzing data in adverse or fragile contexts where the government or others may not be supportive or may be adverse to Christian health services, we'll really want to be very careful and provide a level of anonymity of who those facilities are if we're doing some kind of summary rollout. Absolutely.
Thanks, Doug. And thanks for the question, Dan. We have another question from Sally Craig Huber. And the question is, will you be collecting data about source of funding, such as out-of-pocket fees for service, external donations, local donations, government subsidies? That's a great question. That is a piece of information that we haven't asked in the registry. It's not in the registry right now, but could possibly consider adding that in the future. When we set up the type of questions that we wanted to ask, like ownership, geography, we wanted to keep it somewhat broad so that organizations filling this out don't feel overwhelmed, or that, you know, it's a huge list and it gets overly complex. But there are some questions that maybe we should be looking at adding, and I'm sure that this is just the first iteration. So comments like these really help us to look at what are some other areas that we may have been missing that we should ask about. So thank you, Sally Craig.
Carolyn, maybe can I make an additional comment on that too?
Please.
Because one of the interesting things is that some people have more data and more information than others, and so I'm going to call out for, you know, here for just to illustrate my point. We've done some work with the Christian Health Association of Ghana, and early on in the partnership, we asked them some questions about health facilities that are under CHAG's umbrella, and they immediately, with gosh, I think I asked a question, and within 45 minutes they sent an Excel pivot table that analyzed the data for us. So it made it clear I didn't need to have that data in a warehouse. I didn't need to collect it. If I needed that information, I would just go straight to that source. And so I would imagine in some countries, not all, their data sets will actually have some of that information. So we want to capture whether that local data set has that information. Now, whether we start creating an architecture for that or start collecting that information, maybe that's something down the road we'd want to consider. But at minimum upfront, we just want to know who's got the data, be able to access them. Data is dynamic. You know, one of the things that Scott Todd has really helped us understand is that this is not a static world. There are a lot of other initiatives. There's many of us know about DHIS2. We've already talked here about the WHO's work in this. There are other platforms that are coming out to advance data and mapping data as well. And so it's not a static world. So we have to think dynamically also about this registry and make sure that we can keep up with the evolution of that data and just keep pointing to who's got that data instead of viewing it that we're going to try to house it all ourselves.
Good point, Doug. And I think that relates to Jim's comment here, which is a good one. Consider quantifying contribution to Ministry of Health data tracking often trickles up to WHO. For example, ALM and partners provide significant data on case detection, prevention of disability, and official drug supply for leprosy. And so I think this is a really good point. As Doug mentioned, we know that this area is messy and we don't expect to be the ones to clean it up, if you will. So we know there's a lot of overlapping data, a lot of faith-based data that is going to be tracking up to ministries of health and others. And we want to make sure that this isn't a siloed effort, that we're really communicating with partners in country, with public entities, to make sure that we're collecting summary data in the right way, but also to make sure that there is that communication and collaboration between overlapping sources. So thanks so much for that comment. And then we have another comment from Matthew. One challenge that you might face is the institution functioning optimally, or is it only there on name? Many institutions in developing nations are not optimally functioning. And two, there are Christian health care providers who are running small primary care programs on their own in remote and hard to reach areas. Will these get included or only church-owned established ones? So I think for the second point, referring back to Stephen's question and that discussion, yes, we're looking at all types of Christian health assets, not formally established one through church or NGO. So I hope that answers the second part. But number one is we've definitely run into that and seen that in a lot of places where a facility or a program is Christian by name only. And so we want to be careful about even the analysis we were doing with WHO data, looking at facilities with faith in the name or saint in the name, that we are not taking this at surface level. We're not making any big statements, or we're saying with 100% we know that this facility is this. We're just trying to get a broad idea of the scope and scale, who's working in this country, what their data records represent, and moving from there. Doug, do you have any more comments on that question or comment?
I was going to type out something here, but I'll say it. It's a really super question, and underlying it, frankly, is something about the identity of Christian health actors. And there are lots of organizations that still have or have the name Christian, but you don't see much internal identity of what is Christian, never mind quality, just in terms of identity. So we're actually piloting a tool. I know, I think Rebecca is on, and colleagues from HAP are on. We're piloting a tool with IMA World Health and HAP to actually see how organizations align their faith identity with their operations. That's a brand new thing. And just trying to see, what do you think how integral is faith to your internal and your external operations, and then how do your operations actually align to that? And so we're working on that. That's the CCIH thing, not so much part of this consortium.
Thanks, Doug. And good comment from Dan. Thank you so much for those suggestions. Ray Martin has a question. Is the WHO interested in participating, or at least relating to this initiative? And I think I'll turn that question over to Doug.
Oh, great. I'm getting the hard ones here. Ray, it's a great question. And I think many of you who've been tracking what's happening at the WHO know that there's a considerable uptick in their engagement with religious actors, not just Christian, but all faiths. And we're so grateful to see that. Over the past year and a half, there's been a tremendous uptick in that. They, of course, have a lot of work that they do on what we've already described, the WHO master facility record data. I think part of what we'll do is do some analysis of that. We actually have that in our short-term plans, is to do some analysis of the WHO master facility record data. Again, these are things that Scott has really helped us to understand. Once we do that analysis, we go back to WHO and say, can we work together to make this all better? And that's the starting point.
Thanks, Doug. I see, Bruce, you've raised your hand. Feel free to unmute yourself, and this will be the last question we can take until we move on because of time. Thank you.
Sorry, it's not really a question. It's just to let people know that CHA has been asked. I've been part of the Faith Network for WHO for the last couple of years and helped to develop a system of webinars for faith-based organizations at the end of last year, and they have officially asked CHA to join an official faith network that they're beginning, and so we have to go through all the vetting and so forth, but it'll be a great avenue to bring this to them as well, potentially.
Thanks, Bruce. And I know I said that would be the last question, but Michael just sent in a really good question about what would be the critical role of CHAS in this. We're so glad that HAP has been a founding partner and has contributed a lot to the planning of this. I think in this coming year, one of our big initiatives will be reaching out to the CHAS and making sure we have updated and accurate representation of CHA data in the registry. But Absolutely, that's such a good question and point. We are really trying to reach out and make sure we have updated data from the CHAs and collaboration. I think we are very open to having individual CHAs participate in the consortium as they would like, and so that is really good to bring up. Thank you, Michael. And thank you so much for the additional insights, Scott and Yasmin. I think, Hannah, if we can move to the next slide. So I wanted to quickly share our next steps. You can see our next year, the big highlights planned out. As a consortium, we'll be meeting quarterly. And then in between that time, I'm sure we'll gather feedback. One of our initial priorities, as we mentioned before, was setting up the platform and hub so that we can get people focused on one area of filling out this registry, of gathering more summary descriptives of what data is out there. We will be working on a data governance agreement for the consortium to really help highlight privacy concerns and other data governance concerns. Gathering a list of resources that we can be sharing, analyzing the WHO data, which we talked about during the discussion time. And then also what we recently discussed with Michael's question is really focusing also on getting updated analysis of HAP, CHA data and collaboration with CHAs. And then we plan to publish an annual report at the end of the year. Thanks, Hannah. We can go to the next slide. So now we're off the ground. We would love for you to spread the word. We have a preliminary landing page while the hub is in development. So on the landing page, you'll be able to see our goals and objectives, more information on the Christian health landscape. And so you'll be able to also download a 2-pager. So what is projected on the slide, that is a nice PDF that you can send around and take a look at for any interested parties. But we're really happy to have these 2 resources that are very shareable and have good basic information about the consortium. Next slide, please. Thank you so much for joining us. Please reach out if you have any questions, if you're interested in joining, want to hear more info, get on a listserv, any of the above. Please email mapping.consortium@ccih.org and we'd love to collaborate. We're really happy to share this about this consortium. We're happy to have this launch today, and we're so thankful for all the participation. Thank you for your questions and your comments. You've been a really engaged group this morning, afternoon, and evening, wherever you're joining from.
Echoing my thanks to everybody. Really appreciate it. And thank you, Carolyn, for leading us through this. And thank you to all of our founding members. You know, again, we'd be nowhere without Bruce and Catholic Health Association, the folks at HAP, International Christian Medical and Dental Association, Dalton Foundation, World Council of Churches. I think Moai wasn't able to join us today, unfortunately. And I think, and then us, is that it? That's a pretty solid group. Please join us if you are interested in this. Thank you.
Another thank you to Amanda from Usaid for your remarks.
Oh, indeed. Thanks, everybody.
And have a great